From the JAMA Network, this is JAMA Psychiatry Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Psychiatry.
Hello, and welcome to our listeners around the world. You're listening to JAMA Psychiatry Author Interview Podcast. I'm your host and web editor, Dr. John Torous. Today, we're thrilled to be discussing a new paper just out in JAMA Psychiatry, Tailored Weight Loss Program for Adults with Serious Mental Illness, a randomized clinical trial of Coach to Fit. We're about to talk with two of the authors of the paper, Matthew Chinman, PhD, and Amy Cohen, PhD, from the Center for Healthcare Evaluation Research and Promotion, Veterans Affairs Pittsburgh Health System in Pittsburgh, Pennsylvania, and the American Psychiatric Association in Washington, D.C., respectively. We know that the single greatest cause of premature mortality in people with SMI is cardiovascular disease. Yet sometimes it feels like everything is stacked against us, helping patients to be healthier or lose that weight. Many classical antipsychotic medications may increase weight gain, and many aspects of serious mental illness itself can make patients less likely to be able to lose that weight. So what if there's a new approach and way that we could help patients? To learn more, we're about to talk with the first and last author of a study published earlier this month in JAMA Psychiatry on the very topic. So thank you for joining us both, Dr. Chinman and Dr. Cohen. And let's set the stage and discuss what are the facts about weight and health risks in people with serious mental illness, or we'll call it SMI, throughout this podcast.
Thank you very much for having us. We're really excited to be here. Adults with serious mental illness, they definitely have higher rates of overweight and obesity than the general population. And there's multiple factors, as you mentioned: psychiatric medications, sedentary behavior, poor dietary habits, smoking, poverty, limited healthcare access, and cognitive impairments and social isolation. So yes, the deck is really stacked and their life expectancy is lower. And not only that, SMI can contribute to your poor health, but then also your poor health can in turn make your SMI worse.
So it really is a vicious cycle.
For sure. And there are lifestyle interventions that are effective for people generally. Lifestyle interventions have been around for many years, and there's a lot of studies on them. And they usually involve things like diet, diaries, and group exercise sessions and education, trying to get people more active and providing ongoing support. And there's a ton of evidence that those can be really helpful. However, one of the problems that we've seen is that these programs are not the best for folks with serious mental illness because they can be complex to participate in, a lot of things to read, a lot of things to do around these like diet journals. They often require going places, so transportation that they might not be able to do. They often involve participating in groups, which folks with serious mental illness have actually told us in qualitative studies that they don't often like to do. So there's a lot of barriers that these lifestyle interventions have for those with SMI that make it hard for folks to take advantage of them.
That mirrors what I've seen. For some patients of SMI, I've prescribed some of these medications, and I know that lifestyle interventions are the key to helping patients not gain weight, but sometimes just engagement and adherence has been really tricky for people to get those results. What's interesting in this work, through your work with the Veterans Health Administration, we'll call it the VA has had this program called the MOVE program. What is it, and how does it begin to help tackle this challenge?
So this is Amy. Thanks for having me. You know, the MOVE program at the VA, the longer name for it is the MOVE Weight Management Program for Veterans, has been around for almost 2 decades. And if you think about what Matt Chinman just said about what's difficult for these kinds of clients, unfortunately, all of those parts are how MOVE works. It's a 16-module program, in-person, group-based. It's run by a 245-page workbook. So there's a lot of reading, extensive handouts, meal diaries, and calorie tracking. And that's just a lot. To be honest, it's a lot for anybody, but it is definitely a lot for individuals with serious mental illness. Across the board, if you look at the eligible veteran population, just anybody with any diagnoses, any veteran, we have less than 5% who take advantage of this program, and even less with SMI. And so, John, it's evidence-based and it's effective if you attend 6 or more. But even of those people who sign up, half of them attend 1 session. So we just don't have success there.
That's why the MOVE program has an exclamation point at the end of it, because it's in the name, because it involves a lot.
It involves a lot. And clearly we're going to talk about the great work that you've done. And to set the stage, how can technology help here? I think all of us know that technology is not a panacea. You can't just appify everything or AI everything. How could technology help an evidence-based program like MOVE be more effective and help more veterans?
Yeah, I mean, I think the thing, John, is the technology allows for a lot of tailoring. So you can take those 16 MOVE modules or other modules and you can deliver them on the person's own pace. They can repeat it. You can present really explicit navigational aids, plain colors, shallow hierarchy in an app, a lot of things that help with the cognitive deficits that we see in this population. So we just felt like app delivery also reaches people at home, wherever they are. And so we really felt that technology could be and should be tried with this population. But I'll just say one little caveat to that. We feel very strongly that delivering an intervention with an app is best supplemented with some human contact.
Let's talk about prior studies and work related to the current study. Clearly, you are building off some impressive earlier work to kind of add a technology and a peer component to the MOVE program. So what was that background work that you all built off?
So there's been a variety of studies that have tried to tailor weight loss for those with serious mental illness. There was the STRIDE trial published in 2015, which used peers, but not technology, but found some impressive differences in weight loss and cardiovascular fitness. It also involved a lot of these other pieces. So it was a very intensive intervention. And then there was WebMove, which was a precursor to Coach to Fit, which it did use peer coaching and some of the same kinds of education that we use in Coach to Fit. But it was delivered via a website, not an app. And the big difference there is that with an app, you can have it with you all the time on your phone. And it didn't capture the data, which is another really big piece of Coach to Fit and gets to the tailoring that Amy mentioned. It didn't capture the data about your weight and the steps that you've taken and the modules that you've completed and the goals that you achieved. That's a big part of Coach to Fit. All that data is sent to a dashboard that the peer coaches can use in their coaching. And it didn't have a dashboard that Coach to Fit has that helps guide the peers in their conversations with their veterans. So it was a good first step, but we improved on things for Coach to Fit.
In the paper, you note this is a randomized trial of Coach to Fit. A 6-month intervention for veterans of SMI and obesity includes weekly calls from a VA peer specialist. We have this human component, and then we have some tech components. You write a Bluetooth-enabled scale, a fitness tracker, and a smartphone app that provides health education and tracks steps, goals, and weight. Let's quickly break down these different pieces we just talked about, the human part and the technology part, to really understand what is Coach to Fit.
Yeah, let's break it down. So the first thing that happens after you're enrolled is you get an app, the Coach to Fit app, put on your phone. And then for the study, we also gave people a fitness tracker, something that you wear on your wrist. We didn't use Fitbit, but that's a similar kind of device. And then we also give you a Bluetooth scale. So those are the kind of the physical sort of tech pieces. The app and the scale and the fitness tracker all work together. So whenever you step on the scale, the Bluetooth scale beams the weight to the app, which then sends it to this dashboard that I mentioned earlier. Same with the fitness tracker and steps. The app itself is loaded with 22 educational modules, roughly split between diet and exercise. The app then prompts the veteran to look at that and then sort of consume that educational material. Then at the end, it then prompts you to pick a goal from a drop-down list that is tailored also and related to the educational module. And then all of that information, the steps, the educational module, the weight, the goals, it's all sent to that dashboard that is updated regularly and then reviewable by the peer specialist coach. And that coach is the human side of this. In VA, there are about 1,300 of what we call peer specialists. These are people with mental illnesses and substance abuse backgrounds themselves that are then certified, trained, and hired by VA to provide assistance to other veterans with mental illness. And so they were kind of a ready source to use as the coaches. The coaches meet with the veteran every week for 6 months. And they do things like they go over the education that the veteran just looked at. They talk about the goal that was just chosen and how the veteran is doing on that goal, try to troubleshoot any difficulties they have with that goal. They're looking at their dashboard to see what the progress is. That happens every week. But the biggest thing of all that the peer really provides is praise, encouragement. They build a relationship. And they also do what we have called soft accountability. Because the peer is a veteran and they're working with a veteran, and we've done some qualitative interviewing about this, in which the veterans say, well, we don't want to let Fred, which is one of our peers, coaches, down. He's been helping me and I want to do it for him. And that's how it starts. But then over time, they really begin to do it for themselves. One other piece that the peers do that's really great is that they often also work on other issues that are going on in the veteran's life that can be barriers to weight loss and healthy eating. For example, one of the veterans was this woman who was a hoarder, and her house was so full of stuff that she couldn't even do any exercise in her house. The peer worked with social services, the VA, to clear out the house, and then she was able to exercise and lose weight. And there's lots of examples of trying to clear the deck to make exercise and healthy eating more possible.
But definitely a very nice use, and I guess stress of peers, right? Having lived experience, really driving this intervention and giving them technology and giving the patients technology to really kind of facilitate that connection by getting a sense this is a peer intervention augmented by really cool technology. To see how well this worked, what was the goal and hypothesis for the study? Now we understand what is coach to fit.
It was very simple, the coach to fit condition, and then there was usual care. Usual care was just anything that they wanted to do. We didn't put any restrictions on them. So it was just those two conditions that the folks were randomized to. And we thought that coach to fit would lead participants to lose more weight, both an average weight over time, and also have, as a group, higher numbers of participants achieve either 5 or 7% total weight loss by 6 months. And 5 and 7% is notable because, and the literature differs in this, at that threshold, the human body starts to realize a lot of additional health benefits for weight loss when you cross that threshold. So it's an important number in this field to kind of shoot for. So we thought the coach to fit group as a group would have a higher number who would achieve that threshold. And then we also had something called the 6-minute walk test, which is basically how far can you walk in 6 minutes, which is a measure of cardiovascular fitness. And we thought that participants might have a higher amount in coach to fit.
And speaking of participants, what type of person was eligible for the study? Clearly, it sounds like you have to be a veteran since this is a VA study.
Correct. Yes. You have to be a veteran in the VA. We recruited folks, from the VA system. They're all adults over 18. And then you had to have a medical record diagnosis of a variety of different kinds of mental illnesses, schizophrenia, schizoaffective, bipolar, major depression. And then you had to have a BMI of 30 or higher, which is the technical definition of obesity. And you had to have a phone to receive this app. You couldn't be pregnant or nursing or inpatient or have had a history of bariatric surgery, those kinds of things.
I'll just say we know now in 2025, most people with SMI have a phone. That's not a barrier to the study. So we won't even cover that question. But let's jump to how many people were enrolled in the study and what does this final sample look like that you enrolled?
We had 256 folks that were enrolled, split between the two groups. There was an attrition rate at 6 months of 29%, a little higher than we had wanted. Final analytic sample is about 170, about 85 per group. So that's the sample that we had.
What were those primary outcomes for weight and body mass index?
Yeah, so we measured their weight on a scale at baseline and 6 months for the paper. We're also going to do a follow-up that we're in the process of writing up. And then, we recorded their height, so we were able to calculate BMI. And then we also set up cones and had people walk for 6 minutes as much as they could for the 6-minute walk test. And so those were the primary outcomes. We had a variety of secondary outcomes, things like confidence in your ability to maintain a healthy lifestyle, efficacy around eating and exercise that we're going to write up in a separate paper.
So now let's discuss the big question. What were the primary outcomes and results for weight and body mass index?
So the weight was significantly improved for Coach to Fit over usual care. So the average was about 7 pounds lost across the whole Coach to Fit group compared to only 3.5 pounds for usual care. But what was even cooler, I thought, was the percent who reached 5 and 7% weight loss. So for 5% weight loss, 37% got that for Coach to Fit, only 22% usual care. For 7% weight loss, 23% in Coach to Fit reached that, only 8% in usual care did. All those were significant.
Very impressive, given we just know how hard lifestyle interventions are even for people to engage with, let alone get these results.
We were really pleased with that. In terms of 6-minute walk test, there was a small differential improvement for Coach to Fit, but not significantly. But we did see some really nice results with average weight loss and then the percent who met those weight loss thresholds.
And then again, considering this is an intervention, it works, people are losing the weight, how can clinical teams today begin to apply these results to help their patients with serious mental illness of SMI?
We are trying to disseminate Coach to Fit throughout the VA right now. For example, the VA has its own version of Shark Tank we are applying to, and we polled all 1,300 peer specialists in the VA and got over 50 responses of folks who want to do this. So there's a lot of interest, and we're just, we're trying to spread it. But in the meantime, we think clinicians can do a number of things that is suggested by Coach to Fit without actually adopting the program formally. First, taking an active role. So meeting regularly with the patient and providing encouragement and that soft accountability. Anybody can do that. Like, you don't have to be a peer. Any provider can do that. Clearly, some folks need some basic nutrition and exercise education. That's just sort of like a floor. And then also just setting up a plan and helping the patient set up an exercise and eating plan that uses concrete goal setting and then regularly checking in on that plan, I think would go a long way. And then if patients are willing, have them share some of their data. I mean, you don't need necessarily a fancy app to do that. And so anybody could likely share their step data on a regular basis. The whole idea behind this is sort of exercise as medicine. I know that's, I think, becoming more popular.
I like that because those are practical things that anyone can do today that clinicians can help with. And I know we're a little bit low on time, but one question that I think is interesting is we know that Coach to Fit had, again, these amazing peer specialists driving it in different parts of technology. I know the study doesn't tease it apart, but what aspects of the program do you have a sense or just have a gut feeling may have been most helpful for people?
I really feel strongly, and Matt and I have talked a lot about this, that the peers were the magic sauce. And when you think about how you can implement this at other places, I think interviewing peers who can be really excited, approachable, encouraging is really where it's at. Of course, the app provided structure and tailored education, but peers being able to see what was going on with them every single day and be able to tailor their coaching to what was going on with that individual. We always talk about meeting a person where they're at. That's what the coaches did. And then I'll just throw out there that being able to participate in an intervention remotely is a big plus.
Yeah, I totally agree. The peers, I think, were really, in a sense, they were supercharged by the app and the technology to allow them to be even better than they could be on their own.
I think peers are often underutilized in healthcare, and a program like this really brings them to the front and center and shows how powerful they can be. So that's all the time we have, but this was a fantastic conversation. Again, I'm John Torous. I've been speaking with Dr. Chinman and Dr. Cohen about a tailored weight loss program for adults with serious mental illness, a randomized clinical trial of Coach to Fit. To learn more about this research, you can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Shelley Steffens at JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.